a very good evening to you. I am Lisa Lord and we are continuing our chat. This is part 2 with veteran pediatrician and neonatologist Dr. Clyde Cave. Dr. Cave, last week in part 1 we dealt with premature babies, some of the common childhood conditions, we dealt with childhood immunization. Now I want to deal with immunity. And my mother would always tell us when we were growing up that children need to be exposed to a certain level of germs to build up their natural immunity. However, during COVID, we had young children who for 3 years had to wear masks. They were constantly sanitizing. Did that have major implications on their natural immunity?
I think less than we think, because they would catch up. So there may be a period where they are a little bit more susceptible to some things. But we've taken over that exposure to serious diseases by an immunization program. And there are things like colds that don't have long-lasting immunity. So they would catch up. I think the major impact is more, and there has been a major impact on the social things that they were deprived of, the educational opportunities. There are certain things that kind of have to happen at a specific stage of development, social development particularly, to bring on those kinds of essential skills like sharing, negotiation, respecting others. I think those are the ones that may well have a much longer term impact. The other thing that we saw was on individual stress, the amount of anxiety in children from being confined to an environment that may have had concerns about the spread of the infection, vulnerable family members. There were economic concerns during that time, and they were confined to a household where even if they weren't part of the discussion, that emotional tone would have spilled over to them. They wouldn't have had the opportunity to be away at school or playing out in the pasture and being separate from the real adult world. I think they were immersed quite early, and a lot of kids are really smart. They get these attacks not just in the home, but also on media, television, social media. I think that is going to have a much longer and deeper impact than just the actual isolation from diseases.
And in terms of this anxiety that you were seeing, what ages are we looking at?
Quite pervasive and quite surprising to me, because you never used to have such anxious 6 or 7-year-olds expressing concerns about global warming or will the country exist when the tides rise? Issues which you hear some adults discussing, others seem to ignore it quite happily. But at certain stages, children are quite literal and they are very self-centered. So they take this very personally. And they're being taught in schools a lot more world awareness, extinction of species, what their world is going to be like in 20 years' time. And I don't know that we are as reassuring to them as we need to be. Not that I think we have a lot to reassure them about, because there are things going on in the planet that we don't really know about. But they're being taught as part of their reality to conserve and to recycle, and they're not necessarily seeing that happening in their immediate home environment, and that's generating stress for them.
You spoke about certain developmental stages, and we didn't deal with it in part 1, but take me through from newborn to, let's say, adolescence. There's certain milestones that a child is expected to hit. As simple as they might seem, take us through them.
So some are more important than others. We generally define the milestones as motor, meaning movement, either gross motor, like moving your hands or walking, or fine motor, like writing and playing computer games. Speech, language, special senses, and cognitive development, which is learning and intelligence. The motor bit is, I guess, the simplest thing. Baby is completely dependent. They can't do very much effectively other than suck, which they need to feed, and the parent or caretaker provides everything else. And then the motor development starts with control of the head, and neurologically it moves down the body. So the first thing we will test for is a baby's ability to hold its head upright. When you first hold up a 6-week baby, they're head bobbing, and then they have better control and start to use their upper body. So by 3 months, they're able to get their hands forward, and then they have control to their mouth. And as they go on to 4 months, they have control of the spine. So they can then look and discover their toes at 4 months. And then they're able to sit at 6, 7 months, and then they're able to stand and walk somewhere around a year. Now, all these milestones that you will see on milestone charts are the latest normal time. There will be some variation, and most children should be doing it before those periods of time. But you want to check to see that there is progress and there's no real deficit.
And children now are being diagnosed with more disorders. Let's look at autism as one of the more popular disorders.
Right. Autism seems worldwide to have increased. It's been redefined in diagnosis, so there's the autism spectrum, so we're no longer just looking at the severely autistic. And at the heart of the diagnosis is difficulty with social skills. There may be other things combined with it, and the earliest manifestations are problems with speech. So really, screening for speech milestones could be an early indicator of something broader like autism. And in fact, we're seeing a lot of cases where children at 2 and 3 don't have the communication skills that they should. You can detect that in an office visit. And what's been surprising to me is that sometimes the schools have not detected it, or they have spoken in such gentle terms to the parents that the parents don't take it on as a significant potential problem. Now, there's some children who are not speaking at 2, but when you examine them, you know they are taking everything in, they're processing it, they're just choosing not to talk, and when they're 2.5, they may come up with a complete sentence. And then you'll hear Granny said, oh, his father did that too. You know, they are those, but they're also children who have difficulty maintaining eye contact. They play by themselves. They don't interact with the group. They do what's called parallel play, where they'll be sitting and playing alongside but not interacting with. They don't like physical or close personal contact. Those are the ones who, when you look more closely, may well be on the autism spectrum. And it's not necessarily that they are intellectually impaired, because in fact some of them are above average in their intelligence and extremely bright. It has to do with that socialization and how much stress things that we take for granted puts on them, which then causes them to react in a way to minimize that. So then you get the other typical autistic behaviors where they spin around in circles, or they flap, or they walk on tiptoe, as a way of neurologically calming the stress of a social interaction. So it's something that once you're aware of, and nursery schools should be aware, and in particular speech therapists or speech assessments should be able to pick up, around the 2-year-old mark.
I'm listening to you, and we just discussed COVID and the stress that children were under. So you're going to have, let's say, a 3-year-old who went through COVID, was born in COVID, during COVID times, socially awkward, very stressed out, doesn't know how to interact with children. How then do you make that diagnosis? Because there is a spectrum that is quite vast.
We certainly saw a lot of those, and rather than go through full autism spectrum, you put them into nursery school, and within 6 months, you've seen a complete catch up, whereas the autistic ones, those characteristics will remain. So, yes, that reintegration of children who are mimicking other things was difficult. I think we're kind of mostly out of that now, but we are seeing similar problems in children who are homeschooled if the homeschooling doesn't take into account the need for social interactions, which can't be provided in the house. They need age appropriate opportunities to play physically and socially.
Are doctors making more diagnoses for autism now, or because we have more cases, or is it a situation where we didn't know what to look for before?
Probably both, but definitely more cases. When I came back to Barbados in 1990 from my specializations in Canada, soon after that, they started to see increases in numbers, and you'd go back for continuing medical education sessions. And, when I trained, autism was 1 in 200. And I remember one year it had been down to 1 in 120. And they were saying, oh, you must be seeing this in Barbados too. And I was going, no, we're not. I'm sure in a small population we would know about it. We would have had a few of the extreme ones, but we weren't seeing the others. And I think there's a lag of about 15, 20 years before we started to see the increases. In the USA now, in some populations, they're saying 1 in 60 children is on the autism spectrum. And I don't have statistics, but anecdotally, at least every 2 weeks, sometimes once a week, I'm identifying a new case that seems to be on the autism spectrum with concerning behaviors. And this increase is also borne out by the speech therapists, who obviously are oftentimes the first ones because of the delay in speech who are identifying it. And people who run nurseries are saying, well, we have more and more of these special need autistic children or autistic spectrum children who may not be the severe needs to have really specialized long-term care because a regular nursery school is too difficult for them. These are ones on the spectrum who, with assistance and identification and therapy, can be in a regular nursery and even on later on in school, but with specific adaptations for them.
Now, you just said that there's an increase. In terms of factors, what could be behind the increase?
We don't really know, which is the bottom answer. At one time, the causes were thought to be psychological. It was about the mother's interaction with the child. I think that one has been debunked a long time ago. The current one has something to do with diet or the biome, which is the bacterial colonization of the bowel and how that affects neurodevelopment. And when you hear the people who are researching it, it all makes a lot of sense when they explain it. And immediately afterwards, if you try to explain it to anybody, it was, okay, I didn't understand really any of that, other than there does seem to be a connection in some way between food and feeding, and at least some individuals who may or may not be individually susceptible.
In part one, I mentioned that diabetes is a lifestyle condition, but in children, and I want you to go into it a little more, it's not a lifestyle condition in most instances.
In most instances, well, I'm not even sure about most, because what we are seeing is the adult kind of diabetes happening at younger and younger ages. Actually now moving down into the teens, where they also have comorbidities of obesity and hypertension. So they are closer to adults than maybe to children. But childhood diabetes, which is almost always insulin dependent, comes on quite quickly, sometimes in clusters, but those children from sometimes a very early age, it was as though the pancreas, which is the body's source of manufacturing insulin, for a variety of reasons, some of which we know, just stop making insulin or the insulin doesn't work. So you have to give them an artificial insulin to control their metabolism of carbohydrates in order for them to function. And then you have the other ones where maybe from overuse or misuse, the pancreas kinds of wears out, which is what sort of more adults have if the strain of the body size or the carbohydrate and sugar load is too great for too long. It used to be in your 60s and 50s, and then your 50s and 40s, and now creeping down where we're seeing it in people at younger ages. You see it in pregnancy, and what that's thought to be is the women who show this gestational diabetes or diabetes in pregnancy. That's a sign that with age and other stresses, they're probably going to develop that diabetes, whereas the acute stress of pregnancy temporarily pushes them into that zone where you can detect the high blood sugars. So we know in our population, whether it has something to do with the genetics, but definitely to do with the lifestyle, this is one of the major risk factors for our society's health going forward.
What are some of these symptoms a parent should look for that their child could possibly be diabetic?
So the childhood diabetes is a change. Usually they lose weight. They start drinking a lot and passing a lot of urine, maybe bedwetting when they never used to be. Sometimes it comes on where they are suddenly very ill. You may not think of diabetes, but they're suddenly ill, vomiting, stomach cramps, have to end up in an urgent care or emergency room kind of setting. And then it's discovered that it's because they are going into a diabetic coma because the blood sugar has come on so high. And when you look at the history, sometimes it's only been a couple of weeks really from what you can determine used to be their normal, undetectable state to when they come down with diabetes.
What's the age of the youngest child you've diagnosed with diabetes?
There are histories of children in the neonatal period. Usually that's a slightly different thing of being born with a pancreatic thing. But 3-4-year-olds, I have friends who've been diabetic since they were 5 or 6, preteen kind of ages, and have lived with that and adapted to that, being insulin dependent, monitoring things, have gone on to have their own children, and when well controlled, can avoid a lot of the complications of eyesight problems and blood vessel problems. Yeah.
Let's look at childhood obesity. How big of a problem is it?
No pun intended.
No pun intended. No pun intended.
It's interesting in that we start with overfeeding children. The feeling is that the obesity that we are seeing now is a result of programming a body's cells to store extra or unnecessary calories or nutrition. And maybe that starts as a baby. Some of the evidence is showing maybe it starts with the mother's diet during pregnancy. It's not just the amount of food, it may be the kind of food and the artificial kinds of adaptations to food to give it a shelf life may be different from fresh consumption of ground provisions. If you use something with artificially changed oil to give it, maybe that's close enough to what the body needs as a building block. It gets incorporated into the structure, but it doesn't work exactly in the same way. Some of these children lose weight as they approach adolescence, but then very early in adulthood, they start putting it back on. And I'm sure you have friends who genuinely do not eat a lot and exercise and follow all the healthy lifestyle rules, and their body just doesn't accept that this is
Yeah.
going to make them lose weight. There's something different about some individuals where and it's not all genetic, because while their parents may have a similar weight problem, and in our population it seemed to be it showed first in the women before the men. But when you look back at the grandmothers, they were skinny little individuals and not the same kind of body type.
And they had a lot of kids, but they never used to gain weight.
And when we look at the change, they were eating natural and physically active as a lifestyle, working in the fields, not necessarily going to the gym. And it was when we started using baby formulas, which had some chemical adaptation to, it's different to breast milk for some sort of reason, and we wouldn't be sure exactly which. We started having access to refined foods, high carbohydrate loads. So you move from a rural living off the land to a urban supermarket availability of food and changes. This seems to have happened, and it's not just with us. This has happened in the urbanization in Africa, in cities where a lot of our populations would share similar genetics, but it's across genetic lines. You see that in all the countries now that as a modern lifestyle effect are coping with massive obesity and new obesity problems, whether it's in the USA or in Asia. But for us, it's right here on our doorstep. And the first thing is to identify that it's a problem, that the baby who is twice the weight it should be is not just cute. It may actually have a problem that in 20, 30 years down the line, it will not be thanking you for the overfeeding. There are childhood things that are easily correctable. For example, if you have to use a formula and not breast milk, the formula is a balance, so you do not add cereal to it or supersize it. You know, some of the drinks, Ensure and the other ones, those are meal replacements, not a beverage to be added to a full
meal.
meal. You know, so we are, when you look at it, you know, our concept of the volume of food a child should eat, what constitutes a snack, for example, you know, in Bajan life, carrots and raisins would not be considered a snack. It would have to be something that comes in a package that's
right.
highly refined. So when we talk about a child needing 3 meals and 2 snacks, that's not what we have in mind, but maybe we need to be clearer as to what is a healthy meal or snack, both in kind of food and quantity and timing. One of the things that we got wrong is replacing water with some kind of beverage that had in sugar, additives, colorants, all of which could potentially have problems. So the New School Nutrition Project, getting back to a more basic and unrefined kind of approach to eating as fuel, not as an enjoyable experience all the time. I think if we take that in the spirit of the advice, should set us up for the next generation or two to really build on things that the Heart and Stroke Foundation and other people have been saying as far as healthy eating and healthy lifestyle.
And children now are generally less active as well. They're inside, they're on their devices.
And as you said, COVID put a real emphasis on that. But also the ability to play outside for a child is dependent on the earning potential of the parents, the time they have to play with the child, the security of the environment in which the parent feels free to let the child wander outside unsupervised after dark, for example. You know, things have really changed, and it's so easy to say, sit in the corner and here's a tablet, and the addictive nature of screens and games keeps that child satisfied in its own assessment, but really poses a lot of potential developmental challenges to that child. And we're finding out more and more of those as time goes by.
Okay, well, it's time now for another break. Dr. Cave, stay with us. You're watching One on One.
Keep it clean, keep it green.
Barbadians, we invite you to get involved and play your part as we clean and green Barbados. Come into your community with media launches, bulk waste collection exercises, community engagement sessions, and giveaways. Get on board. Let's keep Barbados clean and green.
Beautiful, beautiful Barbados.
Want to be in the medicinal cannabis industry? Then it is important to know your numbers. There are 8 licenses, all of which are for 5 years. 2 of those licenses come with tiers. Cultivation has 4, processor has 3. Don't have the money to pay upfront? Then the 60/40 payment plan is the number to know. 60% of the total application fee upfront, with the 40% paid in the first 3 years of the 5-year license. Pay your way either annually, quarterly, or monthly. For more information, visit our website at www.bmcla.bb. Welcome back as we continue our discussion with veteran pediatrician and neonatologist, Dr. Clyde Cave. Dr. Cave, we were looking at lifestyle diseases in children, hypertension.
Silent. For a long time, we would say it wasn't a big problem in children, but a lot of times that was because we weren't looking for it and measuring it. There are certain children that we know have a problem or a possibility of having a blood pressure problem. High blood pressure, those children with kidney disease. A damaged kidney produces chemicals which can elevate your blood pressure. We know that there are certain things that cause low blood pressure in children, particularly the tall, skinny children going through a growth spurt who faint when they're the vasomotor instability of that age. But as a population, it's been relatively recently that we've been measuring everybody and defining norms. The same as cholesterol. We never used to measure cholesterol in children. That was a disease of older. And we're now finding that there are some children who have what seems to be like essential hypertension from an early age or high cholesterol from an early age. And when you look at their family history, we identified adults older with those problems, but maybe it started a lot earlier. So looking for it, what the actual intervention is not exactly clear, but the feeling is that if you can control these factors, you can prevent the kind of problems that would come on in later years. Heart attacks, strokes, vision problems.
What age are we talking about for hypertension and high cholesterol?
Early teens. Younger children, it's sort of harder to capture them and they'd be more unusual to see it then, unless there was a particularly strong family history. But yes, in teenagers, it's now part of regular adolescent health checks. Adolescents from 13, 14 are usually quite healthy. So after you go through the sports kind of related things, the maturity, puberty, sexual health kinds of things, looking for mechanical things like scoliosis or flat feet, then we're also doing blood pressure checks to make sure that they're not in a vulnerable population as time goes by. Checking their weight, not just to see that they are growing positively, but looking to see that they're not overgrowing and setting themselves up from controllable lifestyle choices for problems later on.
Does it scare you as a pediatrician that you're doing hypertensive checks on children?
No, because it's still unusual to find them, and I think it's better to know if you find it than not. What is sometimes surprising, and yes, maybe scary is the word, that it's a young, fit athlete that you would not have thought, well, they're doing everything right. They're being even more active than a lot of the overweight, sedentary game players who you could compare them to. And they're the ones sometimes where you find that the blood pressures are much higher than you would think and borderline. And anecdotally, we have cases in the US where athletes suddenly collapse from something that was previously undetected.
So we discussed obesity, diabetes, hypertension. All of these predispose persons to strokes and heart attacks. Are you seeing more strokes and heart attacks in children?
Not really from these lifestyle things, because these probably early for these would be 20s and 30s instead of 50s and 60s kind of thing. The strokes we have always seen in children because of sickle cell disease in our population. And people with sickle cell disease, one of the vascular crises that they can have is an obstructive blocking of blood vessels. And if that happens in the brain, it could cause a stroke-like kind of problem. The heart problems would be if there was a congenital difference in structure that predisposed them to something like this. We are detecting, perhaps earlier than previously, some of the autoimmune disorders, which were usually more detected in young adulthood. Things like maybe precursors or early identification of SLE or juvenile rheumatoid arthritis. There's always been a few of those kinds of cases. Maybe as we get more vigilant, we are identifying a few more. I don't think anybody thinks that there is an increase to an epidemic of those kinds of things as we would have years ago described the change in asthma or now considering obesity, autism.
With more children being diagnosed with diabetes, you kind of touched on kidney disease. Are you seeing more children with kidney disease?
Not more, but perhaps earlier. One of the things that was always a real problem in medicine, because the kidney is hidden and you don't always get symptoms from it, is if you were born with a drainage problem from your kidneys, you may not necessarily have any problems other than a urinary tract infection, which can be subtle, just present as a fever that's never diagnosed, cleared up with indiscriminate use of antibiotics. And then at 10 or 12, the child would present in renal failure, both kidneys having been destroyed by reflux or obstruction. When you look closely, the child never grew as well as expected. And there may or may not have been times when you could imagine there was a urinary tract infection, but they don't always have to be symptomatic. So yes, we can now make those diagnoses sometimes before birth, where we can see the reflux to the kidneys or the effects, so that you can intervene, put in a drain, and avert that. So I guess we might be identifying those children at an earlier age and being much more suspicious, looking for urinary tract infections whenever there is an unexplained fever, so that we can make that diagnosis, and having access to ultrasound, which is non-invasive and no side effects, where we can just look at the drainage of the kidneys, whereas before you'd have had to do an x-ray with injection of dye, and that was a lot more invasive.
Do we have children on dialysis in Barbados?
There would probably always be some, but they will be very few. And elsewhere, children who are in renal failure would be candidates for a renal transplant. And that's where, of course, we would like to move to for those children who have that kind of effect, because it would improve the quality of their life for many years.
Childhood cancers.
Again, rare. We are very lucky to have specialists in childhood cancers and blood disorders. Dr. Cheryl Alexis was here as part of the university. Now Chantal Brown-Farmer has come back from the Hospital for Sick Children in Toronto and working on a collaborative project with sick kids in Toronto and the other Caribbean islands for early diagnosis and consultation and treatment of children with childhood cancers. So always sad when it occurs, but many of the cancers, particularly the childhood leukemias, early diagnosis and effective treatment can result in as close to a cure as you'd ever want to say in children with a cancer, certainly 10 and 20-year survival rates. But that depends on early diagnosis and intervention. And, you know, we have many of the blocks in place to make that happen here without having to disrupt and go abroad.
Dr. Cave, you would have spoken about premature babies, spoke about babies being born with certain conditions. Let's talk about geriatric pregnancies. You're not an obstetrician gynecologist. However, you would have examined babies born to women over a certain age. And I had this conversation with Dr. Chatrani sometime last year. He does not have a cutoff point once you're healthy enough, etc., to have a viable pregnancy. Where do you stand on that?
We know that there are complications to the mother's health and her ability to have a successful pregnancy at the extremes of reproductive age. So 13 and 14-year-olds can get pregnant, but they're more likely to have problems. You know, 50 and 55-year-old women can get pregnant, but they're more likely to have problems. When you have technology that can intervene, presumably they can make it safer for mother and child. But yes, it would be a more risky undertaking. My concern in a pediatrician is geriatric parents, because a child is very dependent on the ability of the parent to provide for them. And, you know, as in the news, suppose you have a mother who has a baby at 60. I'm not sure many 60-year-olds have the desire or the ability to go with, you know, getting up at night, running behind them. Then you look at that child being in primary school, you know, that parent is going to come last in all the parent races, you know, and the implications for the child, because there's a different mindset as how we view life at different times and different expectations. I would think for teenagers to then have parents in their 70s, it's going to be extremely challenging on both ends. And that's assuming that as the parents age, they remain, and some people do, but not all, in the peak of health, don't have health issues of their own, don't have financial issues of their own, all of which would affect the ability of that child to go on to college and university in a family structure where perhaps the parents' resources at that time would be more diverting to their elderly care rather than continuing to invest. So there's a whole social spillover that even when we address the biology, I think we have to be cognizant of.
Before we started the program, I know you said you wanted to discuss child advocacy from the perspective of both the child protection and child justice bills, which are set to go back before Parliament for debate. Why are these so important to you?
Well, one of the things that makes pediatrics special as a specialty is our responsibility to advocate on behalf of a child. In adult medicine, the patient has a voice and you accept their free will and choice, whether you agree with it or not. Children, the choices the parents make for the child may not always be in the child's best interest. And I'm certainly not saying that the doctors or healthcare workers should take over making that decision, but certainly we have to advocate to the courts who ultimately make the decision. And this is very obvious when it comes to child abuse. A parent cannot in our society do whatever they want to a child just because they are the parent. We set limits, and I think rightfully so. What those limits are, how far you go or how far you don't go, are open for debate. There's a feeling that we don't have a lot of child abuse in our country, and I think that is wrong. I think it is that we don't necessarily recognize or want to know the abuse that exists. And I'm not sure when some of the abuse is uncovered that we have the ability to deal with it. And I'm using abuse not just as extreme physical or sexual abuse, but emotional abuse, the kind of stunting of a child's development by constant negativity and downplaying, maybe even the social abuse of not really having access to anything other than gangs, those kinds of social situations that very much impact the kind of life that a child will grow up to have. So I think addressing it as a society, we are a signatory to the Rights of the Child United Nations legislation and have been for a while. Now putting in something in place to systematically identify and respond to it, but that's really problematic because once it has been raised, somebody has to adjudicate and say this is a real problem or not, which is going to put great demands on the available expertise and the resources to actually intervene. So we either continue to stick our heads in the sand or we make an attempt to address it, but whenever there is social change, there's going to be a lot of resistance. And I think that's a necessary phase that we are now prepared to go through, concentrating on the well-being of the child. For example, child abuse is discretionary now for the healthcare worker or the doctor to be convinced individually that this is severe enough to report. In North America, and what is proposed in developed countries, not just North America, and what is proposed in our legislation is if there is a suspicion of abuse, you are mandated to report. So it's casting a much wider net, but in doing so, you will capture more abuse, but you'll also capture things that may look like abuse and are not really. And you have to have the ability to distinguish quite quickly, because you don't want to intervene and separate a family and 3 months later when the whole investigation is over realize, well, this seemed like a problem, but it isn't really. There's a logical explanation. You will have created harm during that time. So I think thinking it through and resourcing it throughout all the child services, education, medicine, nursing, nurseries, everybody who has something to do with a child, to become more aware, and then for us to have a pathway where we can look to prevent it through the lens of maximizing the potential of the child, not necessarily being punitive to the family.
Is there any case of abuse, and I'm talking about physical abuse, that you would have seen over the years that stands out?
Yes, there are some, but the ones that I more worry about, to be honest, Lisa, are the ones where I had a suspicion at the time and I never knew how it turned out later on. And the more experience you have, the more sensitive you are to cues, where early And I'm not an individual, and I wasn't raised in an environment where I'm automatically suspicious of abuse. Where there's some people, some of my colleagues would say, well, I really wondered about this and this for that reason. I'm going, oh, well, that never crossed my mind. As you become more experienced, you start to wonder. And I know there was a case at the hospital where a young girl came in pregnant and unbooked, consent signed by her uncle because the parents were out of the country. On the postnatal ward, the nurses thought something was not quite right, and when they asked questions, she absconded, and it turned out it was a case of child trafficking. She was underage. The uncle was the pimp, not the uncle. And if it wasn't for the astute observations of the nurses, that would have gone through the system. And there's so many issues involved in that. You know, the mother herself was still a child. I mean, our system of checking, you know, when a new parent brings a child to my office, we don't ask for identification and verification and go through what they're now starting to do as a routine in the States. We take it for granted that the mother is the mother just because she comes with a baby and says, I'm the mother. And yet, sooner or later, that may not be so. And how will we know? So it raises a lot of questions of modern life and technology, but also the child welfare, both of adolescence, which is an area that I think we need to look much more closely and carefully at, but also of protecting very vulnerable young children to allow them their maximum potential. With our population falling, we have to be even more careful of the extreme investments we're making in these children, not just for their own good, which is enough of a reason, but because our society ultimately is dependent on it.
And you also touched on it again, because as you said, a mother might come, well, a woman might come to your clinic with a child, but she's not the mother. And parenting is also having an impact on pediatrics as well.
Yes, there has been a fundamental change in parenting. I think starting with women in the workforce, the grandmothers who used to be at home and to be the knowledgeable homemakers and childminders now have lives of their own, working and contributing to the economy of the family. That leaves young mothers, sometimes very young, under-resourced but not knowledgeable, because families have gotten smaller, so they have not babysat 4 younger siblings, and they really don't know what to do intuitively or who to ask. So for a while, they turned to the polyclinics and the medical and nursing professionals. Now they turn to Dr. Google and chat groups, and the information that they get there is not always appropriate. So how we deal with that transition and provide the resources, from my perspective, primarily for the well-being of the child, but really it's for the well-being of the family and by extension the whole society, because this unit is what everything is going to dependent on. And when you have weaknesses in it, the whole structure is liable to become more and more fragile and collapse. It is always so worrying when you see in the papers young men being involved in the court system and the mother saying, oh, he was such a good boy. These things don't happen suddenly and quickly. There must have been something along the way that could have been identified, and hopefully some kind of intervention provided through whatever. The intersection of health and education can be very blurred, but something so that that individual wouldn't end up delinquent and before the courts.
Something I've always wondered with doctors in general, but especially pediatricians, even after 40 years, how difficult is it to look at parents and tell them something is wrong with your child, especially when it is something serious?
That's difficult. You become practiced with it, and it helps if you are telling them the problem has a treatment and we're catching it, and here's what we have to do to fix the problem. When it's something that has a likely bad outcome or is unfixable, yeah, that's one of the times that it's really difficult. A lot of friends say, how can you stand sticking children and making them cry all the time? Doesn't bother me in the slightest, because once you've seen a child in intensive care on a ventilator, intubated, all spasmed out because of tetanus, preventing tetanus with a 30 seconds of crying compared to what you are trying to prevent, those short-term things don't bother. But yes, especially in pediatrics, we're talking the beginning of a life. We don't have the comfort of saying it was a life well lived, they reached a good innings. Children have so much hope and potential. So if you have to be the bearer of bad news, that is a burden. But hopefully the relationship with the parents and how that inevitability is handled, it can make whatever the problem is easier to see through to what might not be the most desirable outcome, but make the journey towards there easy.
What do you want to see for the field of pediatrics, especially here in Barbados?
I think it's going to be very exciting as we learn the molecular explanations for disease, and we have targeted pharmacology so that they can use your particular genetic and molecular structure to be modified by pharmaceuticals to specifically target your problem that will be specific to you. I mean, seeing that in studies and almost there, coming from science fiction and beyond from when I started. I think that is a very exciting frontier for those individuals who are unfortunate enough to have something significant. But I would really like us to see us do more for those children that we are calling average, who have learning issues that are not the most severe, social issues, personality issues, that with the right intervention we could make them so much better so that they can be the best that they can be, not just be adequate and okay. That glorification of mediocrity that seems to have crept in, leaving them alone when for something more they could be so much better. I would like to see us address that so that children are not just okay, they're really good.
And I know viewers at home are watching and wondering, but how does he look like this after 40 years? You're retired. What's the secret?
I think you work with people who are young and it keeps you young.
You draw the youth from them.
My mentor, Dr. Bertie Graham, looked very young into a very long age. My partner in the office, Professor St. John, who is the head of me in pediatrics, looks extremely young. So I think it's a mindset, or maybe we were lucky with the genetic lottery.
Maybe. But thank you very much for taking the time and chatting with us this evening. I really appreciate it.
It's been a pleasure, Lisa. Thank you very much.
Indeed. Thank you very much. That was a veteran pediatrician and neonatologist, Dr. Clyde Cave. I'm Lisa Lord. Thank you so much for joining us. Do have yourself a wonderful evening.